Yeah, you can go ahead, Aleiandro, to spine conference.
Thank you, Dr. Bryson, for that. I'll go ahead and share my screen. And you should see my PowerPoint. Let me put it on slideshow. Okay, great. So I'll be talking about anterior cervical spine surgery, some history, some considerations, the evolution of it, types of interbody cages, and we'll touch on arthroplasty. As when I do my taxes, not much to disclose here in terms of financial disclosures. So to give you some of the background, the posterior approach to the spine was actually first to be described, and this is just most likely because more superficial, easy to palpate. Later on, anterior approaches, they were initially developed to address non-spinal diseases. The transbuccal approach was described as early as 1896 to gain access to the posterior wall of the pharynx. Then the anterior mandible, tongue, and pharynx were split by Dr. Coker as early as 1911, used to access the upper part of the pharynx for tumors and abscesses. Crow and Williams used the transoral approach to review an osteoma in 1944. And in 1962, Fang and Ong used a similar approach to treat 6 patients with C1, C2 instability. Henry in 1957 described a pre-sternocleidomastoid, retropharyngeal, retrocarotid, so pushing the carotid medially and reaching behind it to gain access to the vertebral artery. But the pre-sternocleidomastoid, retropharyngeal, pre-carotid approach, which is what we currently use, was introduced in the 1950s, first by Robinson and Smith, and then later by Cloward. Cloward described this kind of interbody interbody implant to create arthrodesis in the cervical spine. It was a circular shaped implant that replaced the disc and wedged itself between vertebral bodies, while Robinson and Smith described this flatter implant along the end plates of the vertebral bodies. And then we saw some different types of implants suggested by Simmons and Bala, more of a wedge shape that increased the distraction between vertebral bodies and improved stability and fusion. And Bailey and Bagley, much like Cloward's interbody implant, except it was more square, and this later evolved into what we know as the corpectomy. Early implants involved different types of metal cages. This is one proposed by Bagby in 1988. He worked on horses and worked on horses that had this wobbler syndrome. I think, Abby, I think you need to mute. This young thoroughbred horses developed instability, most common at C3, C4, and what was termed the wobbler syndrome. They became ataxic and were eventually euthanized. So Bagby worked with veterinarians and then reported fusion of the cervical spine with these types of implants. You can see it on the bottom being applied to a human cervical spine, and a similar kind of implant in the lumbar spine and in other joints such as the ankle. And this led to evolution of different types of interbody cages. We have threaded cages, which are themselves sort of a type of corkscrew that gets placed in between vertebral bodies, much like the one that Cloward initially suggested. And this can be packed with bone graft. And then you have non-threaded box cages, which are more of the Robinson-Smith type, go between the vertebral bodies. Some of the early results show that, advantages of threaded cages, they have significantly higher stiffness and accelerated fusion. However, they have decreased maximum distraction and higher levels of cage subsidence due to end plate weakening. But in vitro biomechanical studies showed screw designs to be less stable during flexion and extension and bending. As mentioned, the non-threaded box cages resemble the Smith-Robinson's graft, and from a biomechanical perspective, they mimic healthy cervical anatomy, improving surface contact while maintaining initial stability. So some of the early results show good to excellent clinical outcomes with both a little bit higher with the threaded cages, with higher fusion rates, but higher complication rates as well. And this has evolved to some of the cages that we use today. Today, we commonly see both standalone cages where the screws that affix them to the vertebral body are incorporated in the cage, and they don't have to be screws. They can be plates that wedge themselves into the vertebral body to secure these standalone cages. They receive good to excellent fusion rates with single level ACDF. These fusion rates are not as well achieved in multi-level ACDF. Obviously, these have evolved a lot, but some of the early ones, there were non-union reported up to 40% in 3-level fusions. Anterior plating was adopted to improve fusion rates and reduce the chances of non-union pseudoarthrosis. While they improve fusion rate and they're associated with improved lordotic alignment, disc height, lower subsidence, they do come with their own set of complications. Those include scarring to soft tissues in front of the spine and an associated greater risk of dysphagia. Other complications include screw migration and soft tissue damage, and when inappropriately sized or misaligned plates are placed, this may affect adjacent level forces and lead to further degeneration. Other things that can vary are the cage materials. Commonly used are titanium and polyether, ether ketone, or PEEK. Carbon fiber reinforced polymers have also been used. Titanium is one of the earliest used in the orthopedic world since 1940s and was first utilized for cages of the spine in the 1980s. And then PEEK cages were introduced later in the 1990s as an alternative, and they provide the advantages of radiolucency and an elastic modulus close to bone. So majority of studies have reported improved fusion rates, lower subsidence rate, and radiolucency with the PEEK cages versus titanium. We know from experience with cranioplasties and using PEEK elsewhere that perhaps the titanium is a little bit more resistant to bacteria and propagation of infections. Here you see some of the early outcomes, good to excellent clinical outcomes, with all of them, titanium having a wider range. Excellent fusion rates can be achieved with all of them, with the carbon fiber polymers having a wider range here. Lower rates of subsidence with the PEEK of note. And this leads to modern cage designs where now titanium can be modified by increasing its surface roughness and applying plasma beam and electron spray techniques. This increases the total protein and alkaline phosphatase levels and increases osteogenic cell differentiation. And titanium can be combined with PEEK to take advantage of some of their various properties. And a number of other materials and polymers are being investigated as possible alternatives. This line of research continues to grow. So to talk a little bit about what we're treating here. Cervical spondylosis is a very common condition. Chi, how might you describe cervical spondylosis just generally?
I guess generally it would be just degeneration of the bones and the discs in the cervical spine.
Yeah, that's right. It's a broad term that means degeneration of the spine, which can involve the discs, the bony elements, and incidence is as high as 76 to 82%. However, it's mostly asymptomatic, and it happens most commonly at C5-6, then C6-7, and C4-5 levels, but it can happen anywhere in the cervical spine or the spinal axis. And it can lead to radiculopathies, myelopathies, or combined syndromes. To talk specifically about cervical spondylotic myelopathy, as you know, this is a condition where the cervical spinal cord itself becomes compressed or ischemic, and related hospitalizations in one Taiwanese study were approximately 4 per 100,000 person years. And there's a number of grading scales that have been used to describe the severity of cervical spondylotic myelopathy. One of the oldest is the Nurek grade, and it's well established in literature. Its primary focus, however, is gait, which brings with it some limitations when patients develop other symptoms more so than gait. And it ranges from 0 to 5, 0 being minimal disease, and 5 being chair bound or bedridden. The Japanese Orthopedic Association score is commonly used. It's more comprehensive. It brings into play motor dysfunction of the upper extremity and lower extremities, sensory dysfunction, as well as sphincter dysfunction. Here is an overview of what it looks like, grading the upper extremity symptoms from 0 to 5, lower extremity symptoms from 0 to 7, sensory from 0 to 3, and sphincter from 0 to 3. And as noted here, higher scores mean less symptoms. So mild scores greater than 12, moderate 9 to 12, and severe can be considered less than 9. Another one to note is the European Myelopathy Scale. It itself also encompasses a number of different components: upper motor neuron symptoms, gait dysfunction, bladder and bowel dysfunction, lower motor neuron symptoms, posterior column symptoms, paresthesias and pain, and ranges from a total score of 5 to 18. Here, the higher scores are better as well. And as we know, there's a number of ways of treating myelopathy depending on the pathology that's causing it. Emily, what do you see here on the left-hand side of the screen?
I'm looking at a cervical X-ray laterally, and I'm seeing what looks like sort of vertebral body cage. It's 2, 3, 4. It's 5. I think it's 5 and 6. C5-6. And then I'm also seeing some anterior reinforcement with screws at 4 and 6.
Yeah, these are two different patients.
Right, yeah, two different patients. Yeah.
What do we call this surgical treatment here? This procedure, where you
you have to do a corpectomy and then you have to put in the cage.
Yep, that's exactly right. Corpectomy. We see two different types of cages. This here is an expandable cage, which after placement between the vertebral bodies, you can expanded, as the name suggests, and you can increase intervertebral body height, but also increase the amount of sort of compression of the vertebral bodies on that cage, so that to hold it in place and just prevent subsidence. And then a static cage here, both with plates, is normally done for corpectomy. And then what do you see in the middle here? As opposed to corpectomy, then we have two other ones.
Right, so this is also going to be a I'm seeing implant the disc, I believe. Yeah, they're interbody because they're between their vertebral bodies.
Yeah, that's exactly right. So this is just your anterior cervical discectomy and fusion, and two different types of interbody implants that we discussed with a plate and then the standalone cage, both of which we see. And then on the right, this one is perhaps less utilized. So bonus points if you know what this procedure is here on the right-hand side.
Yeah, it's definitely again an implant for the disc. I believe this one also expands to a certain extent when you put it in, and then it stabilizes the spine in such a way that you don't need to fix.
I think you're noting that it has two sort of surfaces. However, this one doesn't expand. But I'll cover why it has two surfaces in this design here. What else do you notice about this radiograph is what do you notice about the cervical spine in this person? Is there much degenerative disease?
No, I'm not seeing much degeneration, and the alignment looks good as well.
Okay, great. Yeah. So this is called an arthroplasty. Want to talk about it a little bit because there are patients in which ACDF and arthroplasty are both reasonable choices. It's important to know the indications for when to use an arthroplasty, when it's applicable, and if there's any evidence supporting one versus the other in a select subset of patients. So long-term follow-up of patients undergoing ACDF suggests that up to 25% of them represent with significant adjacent segment disease within 10 years of the initial procedure. Chi, I'll go back to you. What are they referring to here with this rib presenting with significant adjacent segment disease?
I think they're referring to complications or the risk of having an ACDF. Things like instability, listhesis, or maybe like the herniated disc, and then stenosis that can happen, as well as some other like potentially fracture as well in the adjacent segments.
They are talking about adjacent segment disease in the context of ACDF, but specifically talking about a lot of those things you mentioned in the segments above and below where the ACDF has been done, right? So there is this this phenomenon and this idea where, doing a fusion of vertebral bodies now creates, rather than mobile independent segments, one larger fused segment that it itself imparts different forces on the discs and bony disc complexes above and below it. And so this can lead to degeneration of those adjacent segments, and that's called adjacent segment disease. And as you can see, up to 25% of patients after ACDF present with significant adjacent segment disease within 10 years. Cervical disc arthroplasty was introduced in the 1960s, initially with little success due to complications of hypermobility and subsidence, but it was introduced as a way to maintain the mobility, the segmental mobility of the cervical spine after treating disc disease. And as this evolved, the development of metal on metal and metal on polyethylene discs has renewed interest in arthroplasty. So this is a design by Medtronic where there are two plates designed to fit up against the vertebral bodies. And between those plates, there's a ball and trough articulation that allows movement of those two plates relative to each other. Similarly, this is a design by Dupuy, and it maintains the same principle of allowing these two plates to move relative to each other and maintain segmental motion in that level of the cervical spine. However, it's important that we define who is a good candidate for arthroplasty. So here we have 3 different patients, and all of these 3 patients could potentially use a anterior cervical spine surgery or a discectomy or disc replacement of some sort. Abhi, why don't you just comment on the pros and cons of using each in these patients?
Yeah, absolutely. So the first patient, you can see a 35-year-old patient with motor vehicle accident, and you can see on the scan that there's an instability and an anterolisthesis of the cervical spine 4-5. This patient would need. This patient is not a candidate for arthroplasty. We definitely need some sort of instrumentation and stabilization. So I would definitely, in between ACDF and arthroplasty, I would do ACDF 100%. The second one is a 60-year-old with acute and chronic neck pain, no gait issues, also low back pain. This patient has a multi-level stenosis, multi-level spondylosis with an age of 60. So arthroplasty on this patient, probably not a good idea, especially given that patient has neck pain, which can signal some micro instability. So I would still do an ACDF on this patient, probably do like a 2 to 3 level ACDF on him. The third one is a 32-year-old with 3-month history of worsening arm pain, C6 radiculopathy. So this is a classic example of a young patient with a radiculopathy, but no significant neck pain and no concern for instability. So the third one would be a prime candidate for an arthroplasty.
Yeah, that's very well said. And just to summarize some of those points, so the prime candidates for a cervical disc arthroplasty are those that, first of all, are skeletally mature. So you're not going to do these in pediatric patients who are still growing. They have little to no degenerative disease or bony changes or affected disc height. They have no arthritis or inflammatory arthritic conditions, no infection, and a stable cervical spine. Looking at some of the evidence now comparing ACDF versus cervical disc arthroplasty. This is a meta-analysis from 2013, giving us some level 2 evidence and collecting evidence from various randomized trials. And it showed longer operative time and more blood loss for disc arthroplasty. However, there was benefit in neck pain scores, arm pain scores, neurological success, motion at the operated level, and less secondary procedures such as supplemental fixation during the time of follow-up in these studies that it collected. It had similar length of stay, neck disability index scores, adverse events, and rate of reoperations or removals of the disc. Later on in the UK, this meta-analysis came out. They named arthroplasty total disc replacement. So TDR was superior to ACDF at 2 years and between 4 and 7 years. In the short term, patients who underwent total disc replacement had better patient-reported outcomes versus ACDF, but at 2 years, this was not a significant difference. Results favored the disc replacement between 4 and 7 years and showed significant differences in neck disability index. The short form 36-item health survey, as well as dysphagia and satisfaction. And most trials found significantly less adjacent segment disease after total disc replacement at both 2 years and between 4 and 7 years. There's a recent meta-analysis, and it focuses specifically on cervical spondylotic myelopathy. This is from JNS, and it showed, again, longer operative time for cervical disc arthroplasty, but better SF-36 and neck disability index scores. There was similar neurological success and similar JOA scores, but shorter length of stay with the arthroplasty and lower reoperation rates. However, can't stress enough the importance of one, indications and patient selection. And there is no such thing as a small surgery. So that's all I have. Thank you, everybody.
Aleiandro, thank you so much for that great presentation. It's been great having you on the spine service. That was a nice review of anterior cervical operations, which are the bread and butter of our service from the cervical disease. I would say that, it's interesting, the history of it, which you nicely outlined. The wobbler syndrome is probably something we can apply to humans as well, the name. I would say that the biggest debate right now in anterior cervical is really the fusion versus arthroplasty, and you nicely outlined some of the data. I think it's clear that in my career, arthroplasty has gone from being the new kid on the block to now an equal, and in some patients superior. The key is trying to figure out which patients. And I think your 3 cases and Abhi's discussion of it was a nice summary on that. And so thank you for putting that together for us.
Absolutely. It's been great being on the spine service.
Yeah, that was a really good teaching session, Aleiandro. You seem to have mastered this area, but I really like the way that you have organized it and the way that you are teaching it.
Thank you, Dr. Beverson.
Aleiandro, great job. Just a few comments. I think that DCM, degenerative cervical myelopathy, as they like to refer to CSM currently, because it includes additional conditions like OPLL, is probably the most commonly operated CNS pathology. That's my impression. I wish I had data to support that, but if we consider how many ACDFs, laminoplasty, arthroplasty are being done, I think that's probably a higher number than any other central nervous system pathology. And one more thing about the arthroplasty, I think that one of the limitations of the arthroplasty is that none of the artificial discs can fully replicate the biomechanics of the normal disc. They get close, but none of them has fully replicated, let's say, the couple movement. When there's flexion, the axis of rotation changes inside the disc, doesn't stay stable. Normal disc has a little bit of, allows for a little bit of compression. So some of the more recent implants, they are better than the ones before, but still we don't have like the perfect disc replacement implant.
Great points, Dr. Marguerite.
Jeremy, any comments?
My main comment is that indications. So I think that I think disc replacement, all else equal, is probably, I think, a better surgery for adjacent segment degeneration and disease. However, that has to be in the right patient. And when you stretch the indication because you think cervical disc replacements are better in everybody, and you start doing them in patients who have significant spondylosis or facet disease or minor instability, I think that's when the patients are not happy. So I think in a pristine young patient with a beautiful, healthy looking disc with just a herniation, and I think that's a great patient for a disc replacement. And then I would just say the other thing is there's some question about myelopathy versus radiculopathy, which we didn't delve too deep into for disc replacement. Initially, people thought they were only good for radiculopathy and not myelopathy, but I think, I mean, I was just at joint section last weekend, and the consensus now is that radiculopathy or myelopathy, there's really no difference. Disc replacement is good for both.
John Hooton, any comments?
I think that what Jeremy said is exactly the direction things are headed. Dan Rue is the big proponent for using disc replacement in myelopathy. And if the myelopathy is a segmental process where it's just at the disc space and you're able to remove the little osteophytic spur, and it's not going behind the body where you have to damage the end plate, most of these myelopathy cases are suitable for disc arthroplasty.
Alejandro, what about for treating adjacent level disease? Is that always a fusion, or can you do an arthroplasty? Let's say you've done a C6-7 or 5-6 or 2 level, and the level above now is going.
That's a great question. Already with one fusion, there's already a different set of biomechanical forces in the spine. I think we definitely need more data on that. I don't know if anyone else has had experience with it, but it's not something that I've seen yet. It's a great question.
Yeah, I don't prefer it, but it is being done. But the trials have not really focused on that. It's more of a niche subset.
I wonder what our numbers are here. We, roughly speaking, are doing 4,000 open cases a year, roughly speaking. I think about 2,000 of those are spine. And I don't know what the breakdown is. This is Tanvir and Jeremy and team. This is for you to get. We are now getting access to the data, so we might be able to answer this question a little easier than we were in the past. But we could answer the question, or that we could address the hypothesis proposed by Con Marguerite that cervical, what did you say, that cervical radiculomyelopathy is the most common CNS operation. We could answer that question from Mount Sinai with